Good evening and welcome to Doctors on Call. Are you dealing with a sore neck or problems with your shoulder, arm, wrists, or maybe your hands? Maybe the pain's centered in your upper back. I'm Dr. Alan Johns from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School Duluth. And tonight we're taking your questions about upper extremity, neck, and upper back problems. Here to answer those questions are our panelists. Dr. Jeff Klassen, an orthopedic surgeon with Essentia Health. Dr. David Rust, an orthopedic surgeon with St. Luke's Orthopedics and Sports Medicine. And Dr. Joel Zamzow, an orthopedic surgeon with Orthopaedic Associates of Duluth. We have great phone volunteers waiting to take your questions at 218-788-2844 or toll free at 1-877-307-8762. Our medical students answering phones tonight are all from Minnesota. Rachel Grunman is from Osakis, Emma Osby is from Spicer, and Casey Riley hails from Worthington. And now on to tonight's program. Well, Dr. Zamzow, one thing that you hear a lot of is rotator cuff problems. Seems like everybody's got a rotator cuff problem. What is the rotator cuff?
The rotator cuff is a group of 4 muscles and tendons that form the deeper muscle layer of the shoulder. So if we just look at the anatomy real quickly, the outer muscle is the deltoid muscle that we can feel, and then it's the next sleeve of muscle. So it forms a cuff of tissue, so that's where the term comes from.
So, Dr. Rust, I assume a lot of shoulder pain is from rotator cuff problems?
Yeah, I think the main function of the rotator cuff is to help the shoulder move more efficiently. There are the other big muscles, like Dr. Zamzow said, that can really provide the power and lifting strength of the shoulder, but without a good functional rotator cuff, the shoulder doesn't move efficiently. It can become painful. And when you look at rotator cuff problems, it starts out with inflammation, tendonitis, and bursitis. You can progress to a small tear. Eventually you can have that tear expand, and eventually as we age you can be left with a large tear, and that's kind of the spectrum of disease.
So Dr. Klassen, so what do we do with rotator cuff problems? If somebody has a rotator cuff tear, does that mean they have to have surgery, or are there other things can be done?
Oh, I think there's a lot of opportunity to address patients on a spectrum of care. Typically, we begin with non-surgical management, so it's in the part that just involves evaluating the patient, understanding what their problem is. From there, there are very simple things people do, such as rest, ice, activity modification. At that point, if they're still having symptoms, they may engage in using some over-the-counter medications like Tylenol or ibuprofen or Aleve if they tolerate it. Later on, as we move in through the care pattern, we'll utilize cortisone injections as an opportunity for non-surgical management, as well as physical therapy. I think is important for people to participate in, whether that's with a therapist or even just in a home exercise program for those people that are able to do that on their own. Surgery becomes sort of that last mode of treatment for those patients who are really refractory to the non-surgical measures.
Okay, well, thank you. Well, Dr. Zamzow, we were talking just recently about a lot of injuries. This is the time of year, there's a lot of ice and cold and people are falling down. Do you see a lot of upper extremity injuries this time of year? And if so, what kind?
Yeah, I think typically for me the most common thing I'll see is wrist fractures, Colles fractures. A person will slip and fall and land on their outstretched hand, and the radius will tip back, and pretty common injury, probably the most common injury we see really in the icy weather.
Okay. Dr. Russ, any other kind?
Yeah, I think the ice is the key, especially in the springtime. You get the melted snow, it freezes overnight, and then if you get a trickle of dusting, a powder on top of that, you really can't see that ice. And so for all those listeners out there, if you have those conditions, that's when you want to be extra careful when that layer of sheet of ice is buried under that snow. You can see clavicle fractures, which are oftentimes treated surgically nowadays with very good results. We've talked about proximal humerus fractures or shoulder fractures of the upper arm. which can be a more difficult problem to treat. Sometimes surgery is recommended, sometimes non-surgical treatment can help. And then obviously there's more than 200 bones in the body, and all of those can be broken, so that ice is keeping us in business.
Oh gosh. Well, Dr. Klassen, you hear about shoulder separations too when people fall down on their shoulder. What is that? I mean, we don't have a model here, but what is a shoulder separation?
What I describe it to patients is your shoulder represents kind of two major joints. One is the ball and socket, and that when somebody dislocates that joint, we call it a shoulder dislocation. The other joint that's near your shoulder is the joint on top where your collarbone or the clavicle meets up with a portion of your wing bone, which we call the acromion. And so we call this the acromioclavicular or AC joint on top. When people fall, that the force from the fall onto their arm, it needs to be distributed someplace, and it either ends up through going through the ball and socket, and it may cause a dislocation or a fracture or a tear of the rotator cuff, or that force may be distributed out through the collarbone and the joint, the AC joint. And when we disrupt that AC joint, we call that a shoulder separation.
Mm-hmm. Is that, Dr. Zamzow, is that something, how do you treat a shoulder separation?
Well, mostly non-operative. There were basically 6 types classified in our literature, and the most common types we treat non-operatively. In the very widely separated ones, there are surgical options to fix them. But they're actually pretty rare. Most of the time we'll treat them non-operatively. And interestingly, hockey players, we're always told to never fix them because they're going to fall on the ice and do it again. So
is that right?
Honestly,
that's interesting.
We actually treat them differently than maybe the non-hockey players, honestly. Uh-huh. And that's probably pertinent in our region up here.
I guess, yeah.
Yeah.
So it's not, they'll just do it again anyway.
That's
so
basically that's actually the thought. That's true. Yes.
That's pretty good.
Yeah.
I like that. Okay. Well, we have a caller, Dr. Russ, maybe we can have you answer this question. We have a caller from Duluth wondering about what are the benefits of cortisone shots, and can you have too many cortisone shots? I mean, is that a problem?
Yeah, absolutely. Cortisone is a great short-term pain reliever. It relieves acute inflammation very effectively, but the medication is very detrimental to the tissues. So it causes weakening of the tendons, it causes weakening of cartilage, it can cause over time breakdown of joints and worsening of degenerative conditions. So what I tell people cortisone is very effective for is if you've got a problem that needs to respond quickly to pain, or if you have a very short period of time where you need a window of pain relief, say a trip where you're going to be increasing activity, like a hiking trip, a wedding where you want to be able to have some pain relief and enjoy a night to take care of dancing and not have pain. But it should not be thought of as a treatment for the problem. It should be thought of as a short-term pain reliever that has very significant side effects if exposed multiple times in the same location. So you got to be careful with cortisone, but it is very effective, and I think we all use it extensively in our practices because of that reason, but very carefully.
Great. Thank you. I have a caller from Two Harbors, Dr. Klassen, who wonders about what kind of injury do you get when you sleep on your arm and your arm just feels dead?
Most often I think that's related to when people sleep, they relax, and if they have their arm overhead, I think what they experience is a relaxation of the joint, and the joint may actually shift a little bit on them. That causes you to create some tension both on the blood supply going down your arm as well as the nerves that are going by your shoulder and down into the arm. And if left in that position, such as when you're sleeping for maybe it's an hour or two at a time, you will end up then with either decreasing flow, blood flow, and or causing some relative pressure on the nerves, and that then causes your arm to fall asleep. And that's what people experience then, I think, and it's probably most common when they're sleeping.
Is that something that just goes away then usually? I mean, can that lead to anything serious, or is it?
In and itself probably doesn't lead to anything serious. Does it go away for patients? I think those patients that seem to be susceptible to that, it doesn't necessarily go away for them, and they end up most commonly altering how they sleep, and maybe they alter the position in which they sleep.
Well, thank you. Dr. Zamzow, we have a caller from Duluth who wants to know about rotator cuff surgery, and how long does it take to recover from that type of, that's not something you get over in a week or two.
No, I think it's one of the most lengthy recoveries we see in orthopedic surgery. And the recovery is basically in phases, and there's a protective immobilization phase to allow for healing, then range of motion and strengthening. But I would say for most physically demanding jobs, you're looking at a minimum of 3 or 4 months to recovery. And it's quite different than most things we do. I always tell my patients we can put a hip or knee replacement in. Therapy starts the first day after surgery because the implant is so stable in the bone. But the rotator cuff, we have to protect the repair first. And I think by the time someone has surgery, then protection phase, they're weak, they're stiff, and it just is really a difficult thing for patients to recover. And typically 3 to 4 months.
Interesting. Dr. Russ, I have a caller here who was wondering about, from Grand Rapids, was wondering about what are the treatment options for a bulging disc in the neck?
That's a great question. The disc disease in the cervical spine, usually you're going to try conservative treatment first, unless there's a very discrete onset with associated nerve symptoms. If you have a very significant nerve injury associated with that disc herniation, there may be a recommendation to proceed with surgery immediately, but that would be made by a spine surgeon, either an orthopedic or neurosurgeon who does spine surgery as a specialty. But for the most part, disc herniations are treated conservatively with physical therapy, occasionally with cortisone injections, and trying to avoid surgical treatment. But it depends on how severe the disc herniation is, and probably most importantly, what the neurologic symptoms associated with that are.
Thank you. Dr. Klassen, we have a caller from Superior who would like to know what causes numbness when a patient raises his or her arm above the head, like numbness in the hand and in the arm.
So there could be a number of different reasons why people experience that. There can be vascular reasons for that. It's actually fairly uncommon, but there are very unique, rare situations where people have vascular abnormalities or an extra rib that may be pressing on the vessels coming out to your arm that then can cause you to lose some vascularity to the arm as you raise it up and overhead. More commonly, I think it's probably related to the shoulder itself and whether they have some relative level of shoulder instability. It can be very subtle sometimes. That may cause, once again, similar to my discussion earlier on the patient who's sleeping, the person who's bringing their arm overhead is it's in that same positional piece for people that then causes you to stretch the nerves and then cause some relative irritation and then result in some numbness in the arm. Usually that resolves with bringing the arm down or changing the position of the arm. If it's a persistent problem, then that warrants further evaluation to determine, is this something vascular, is this something neurologic, or is it related to something related to the shoulder like instability?
So yeah, a lot of possibilities.
Right.
Great. Dr. Zamzow, we have a caller from Washburn who wonders about hands or fingers locking. Trigger finger.
Yeah, trigger finger.
So tell us about trigger finger.
Real common. I see it very frequently. I think anti-inflammatories can help. We'll do some injections. I'm not a big fan of injections, They're, I think, very, very painful. And the surgical care is one of the rare things that we could pretty reliably say it will fix the problem. A very easy little 5-minute operation to release the sheath.
So it's
basically,
a tendon. It's
yeah,
a tendon problem,
so basically, you're right. The A1 pulley about right here in my palm, my hand, and usually the most common one is a ring finger. But basically, the tendons get stuck and it starts clicking or triggering, and then sometimes it gets serious enough that it will actually lock down, and it's painful for the patient. They have to take their finger typically in the morning and unlock that finger. So a real easy little surgical fix for it if we can't get them better.
Thank you very much. Here's a caller from Canon, I believe it says. Dr. Russ, this is kind of an interesting question. Somebody falls on the ice, and say they hurt an extremity. Should they put ice on it or heat on it? They already put ice on it, I guess. But,
Yeah,
already put
the answer is you should put ice on it. Ice is a very effective anti-inflammatory. It helps decrease the tissue swelling. That's important because tissue swelling prevents blood to flow to the area of those tissues. So the quicker you can reduce the swelling with a combination of ice and anti-inflammatory medicines, the sooner the tissue will revascularize and be allowed to heal. So treat ice injuries with ice.
very good. I also have a question here from Superior for Dr. Klassen. A caller wondering how common is the reversed shoulder replacement? What is it? Do you know what they're talking about there?
I sure do. The reverse shoulder is a shoulder replacement design. It has been used in Europe for about 20 years. It came to the U.S. in about 2004 when it became FDA approved here in the U.S. The reverse shoulder is probably most common in subspecialty practices that do a lot of shoulder replacement surgery. It is the fastest growing actually joint replacement in our country as far as increase in use over time. And it's related to, in part, our experience has shown that people who that we use reverse shoulder for have responded well and have had very good outcomes, and that's then garnered interest in the orthopedic community to use it, and has been utilizing it in greater numbers than in the past 10 years or so.
Let me add, well, maybe I can ask Dr. Zamzow this. So when we're talking about shoulder replacement, we're talking about that's being done for arthritis in the shoulder or rotator cuff problems. What's it being done for?
Yeah, primarily arthritis. So the standard shoulder replacement would be the standard replacement of the ball and socket joint. And the reverse shoulder primarily utilized for a rotator cuff tear that's not repairable, especially in the appropriately aged patient. So more typically elderly people. So basically the gist of it is that the ball becomes the socket becomes the ball, and it basically, so that's the reverse term comes from. And basically it improves the biomechanics of the shoulder. And it's really kind of a neat thing to see. People will have what's been described as a pseudoparalysis, where they literally can't raise their arm at all because of a chronic massive rotator cuff tear. And after reverse shoulder, typically most people will regain function. It's really quite dramatic for these people. And it's really the first time we have a way to treat this, what used to be a non-repairable situation. Mm-hmm. So I think it's really been a big thing for our patients.
The other area that we've utilized it more now is also in the world of shoulder fractures, which is in part related to our discussions today of people falling on the ice. And it's become a more accepted way to treat proximal humerus fractures or shoulder fractures, particularly in patients who are in the older category, meaning those patients that are probably at least in their 70s or 80s, some maybe even a little bit younger group, and those people in their 60s even. Our experience has grown with that in the fracture world, and certainly we're finding that the results are improved compared to what maybe we had before.
Interesting. Dr. Russ, a caller from Thief River, and this question comes up too. Injection of chicken colm into joints. Can you explain that?
Yeah, so what they're talking about is hyaluronic acid, which is a protein that's found in our normal cartilage. It's processed in a various number of ways. One of those ways is to take it from a chicken-derived protein, so that's where the rooster comes from. It's not actually, any ground-up chicken parts or anything. Those injections, which are called viscosupplementation injections, have had mixed results in scientific literature. And so, in fact, the American Academy of Orthopedic Surgery about 3 years ago came out with some updated guidelines, and they're no longer as a recommended routine treatment for arthritic conditions like they used to be. So what you're seeing now is fewer patients being recommended than were maybe 10 years ago. They still have their uses, and patients still do report success with them. They can be used when alternative treatments can't be used, such as cortisone injections for various reasons, or if patients are just not a candidate for surgery. And so it's something that you have to talk to your physician about and talk to them about the options. And so it may be an option, but in general, compared to maybe 10 years ago, they're falling out of favor.
The other problem, if I can add,
Please.
Typically insurance companies don't cover them except for the knee. That's
Oh,
generally the
interesting.
case, yes.
Is that right?
Yeah, and you wouldn't think that the synovial joint would be that different.
Yeah.
And I have done it in other joints, but typically most insurance companies will not cover it unless it's for the knee.
And that's just for the viewers, that's related to that. The research that was ultimately accepted by the FDA was only on the knee.
Right.
Oh, okay.
And so the FDA approved it for use in the knee and the knee only.
So it's kind of off-label use.
Yes,
at other
and I have
places.
used it in some shoulders and I've been somewhat happy with it. But again, typically it's not covered and it's kind of actually expensive therapy.
Is it temporary?
Yeah, typically we'll get about 6 months or so of relief. So there are people, in some patients, I've done it for years in them and we've had some success, but it's just not, I'd say it's kind of a gray area because the efficacy is, somewhat marginal depending on the severity of the arthritis.
I think it's anecdotal in my practice, but my sense, and I think other people probably, you guys might feel the same way, it seems like the patients whose arthritis is milder
Oh, absolutely.
tends to respond.
Yes.
People that have moderate to severe disease, arthritic disease, don't get that same result.
I think the numbers would say that the mild arthritis will be 90% improve, and the more severe arthritis maybe 50-50. So about in that range. So absolutely, you're right.
Thank you. I don't know who, I've lost track, but that's okay. I'll ask Dr. Klassen about thumb pain. What can you do about thumb pain other than an injection?
Well, thumb pain's an interesting piece because it may be related to a number of different features. In younger people, it may be a ligamentous problem related to injury or instability in the thumb. As you get older, it may be related more to arthritis. So depending on the diagnosis, which once again gets to be kind of a broad spectrum, there are non-surgical things such as splints and or therapy exercises or braces that we can use for people that have thumb-based pain. As we get older, and now we're working more in towards the world of arthritis of the thumb, you can use things like injections or other pain relievers. And sometimes surgery actually is involved to deal with the arthritis in the thumb as well. And once again, that becomes sort of a last solution.
Okay, thank you. Dr. Russ, there's a question for you from Superior. Snuff box was broken last year. We were getting towards the end of our time here. Snuff box was broken last year, still hasn't healed. Is that that's a complication that happens, right?
Yep, so I assume that they're talking about a bone called the scaphoid. There are 8 bones that make up the wrist joint, and they are like an intricate puzzle piece that fits together, and all those bones have to be perfectly aligned to move correctly. And similar to the fall where you can break your radius and get a Colles fracture, you can break that bone in the wrist called the scaphoid, and that scaphoid has an interesting blood supply where the blood supply starts closer to the tip of the thumb and works its way backwards. So the closer the fracture is to the wrist, the less likely it is to heal. And a non-union, which is a snuff box or scaphoid fracture that has not healed, is a very common complication of that treatment. So actually many of those scaphoid fractures are treated surgically when they happen to prevent that complication. When a complication like a non-union happens, then you typically may need surgery, even bone grafting, to potentially repair it. So that's
a tough one.
That's a tough injury.
Well, thank you. I'd like to thank our panelists tonight, Dr. Jeff Klassen, Dr. David Rust, and Dr. Joel Zamzow, and our medical student volunteers, Rachel Grunman, Emma Ostby, and Casey Riley. Please join Dr. Ruth Westra next week for a program on lower extremity, knee, foot, and hip problems, when our panelists will be Dr. Samuel Harms, Dr. David Rutka, and Dr. Joseph Signorelli. Thank you for watching, and good night.